I'm delighted to introduce Penny Birmpili, who is a vascular surgery specialist registrar from the Northwest, and she's currently the Royal College of Surgeons Circulation Foundation Clinical Research Fellow. And we've heard, this is a discussion about critical limb-threatening ischemia. We've got clear guidelines about timeliness to treatment for carotid surgery and even for our aortic aneurysms, and it's very easy to capture that data. The whole critical limb-threatening ischemia is a much more diffuse patient group, much more difficult to capture, but she's going to talk to us about the quality improvement program that we are undergoing and the leading centres that we're trying to identify ways that we can harmonise this service. So over to you, Penny.
Thank you very much. Thank you for the opportunity to present the quality improvement program that we're running for this patient and perhaps attempt to answer the question from Lester. So I will talk briefly about how the program came along and then what we are doing in the program and some of the lessons we have learned over the year that we have been running it. So in 2018, the Getting It Right First Time report on vascular surgery was published, and it found that there is significant variation in the service provision for patients with peripheral arterial disease and chronic limb-threatening ischemia, with too many patients needing urgent surgery but facing long or uncertain waits, and there was significant variation seen across the country. And so they recommended to increase the early availability of urgent surgery for these patients who are at risk of losing their limb, and they recommend that the Vascular Society creates a quality improvement framework with specific timelines for this purpose. So the Vascular Society did publish this document in March 2019, and I will refer to it as the PADQIF, Quality Improvement Framework, and they identified four main aims. Firstly, the provision of evidence-based, well-organized care for this patient population, focusing on risk factor modification, and this is where the control of hypertension and diabetes and preventing medications that Ruth mentioned, such as statin and platelets. Secondly, the equitable access to supervised exercise programs and timely revascularization. Thirdly, the existence in all vascular networks of a multidisciplinary team, and they identified the core members of that as being the vascular surgeons, vascular specialist nurses, sonographers, radiologists, and also diabetic nurses, specialist nurses, and podiatrists. And also the multi-assessment of the patient by various specialties to achieve optimization, such as anesthetists and care of the elderly physicians. So they put all these into these standards that basically describe what I just mentioned, and also underline the importance of the Wi-Fi score or an equivalent classification system and the MDT, and also, of course, the shared decision-making with the patient. But most importantly for the program, they define specific timelines for the patients, and they split into two pathways, the admitted and the non-admitted pathway, with the admitted pathway being patients with very urgent problems that need to be treated in the hospital, such as food sepsis or very severe limb ischemia. And they recommend a timeline from referral to intervention of 5 days. And for the non-admitted patients that still have chronic limb-threatening ischemia but can be managed on an outpatient setting, they recommend a timeline from referral to intervention of 14 days. Now, these targets are extremely challenging, especially in the current service and with competing needs such as carotids and aneurysms, and they recognize that in order for these targets to be achieved, there needs to be a specific pathway that the patients have to go through and urgent slots for surgical review and imaging and revascularization. So where are we currently in regards to these timelines? Where these two charts were taken from the 2020 National Vascular Registry report, where all the vascular procedures are being documented. And The graphs on the left show the percentage of patients with chronic limb-threatening ischemia that are admitted in the hospital as emergencies that actually undergo revascularization within 5 days, and for open surgical procedures and for endovascular procedures. And on the right, you can see actually the median days it takes for the patients from admission to surgery. And you can see here the wide variation. These are the various NHS trusts in the country in the middle that exist. So it really depends where you are in the country, how quickly you're going to have your revascularization. It's not really fair for our patients. And therefore, we decided to create the Peripheral Arterial Disease Quality Improvement Program. So the first meeting was held in November 2019. An expression of interest was put out, and 11 centers in the country volunteered to participate. So they all met and identified what would be the most important thing to focus on, and also what challenges we're expecting to face and potential solutions. So it was decided that the time to revascularization would be really the thing to focus on, and perhaps start from the admitted pathway. So after that, we developed a collaborative, and we followed the Institute of Healthcare Improvement's breakthrough collaborative model that has been used in other quality improvement efforts, such as the Colloquic study from the Royal College of Surgeons. And that means that we have the 11 early adopter centers, and we got 2 more since May 2021, and the Central Pathway team. And we identified that really each center has a different population, a different network configuration, so one pathway wouldn't fit all. So what we did is suggested a number of quality improvement tools, such as process mapping and PDSA cycles, Plan to Study Act. So they could map their patient pathway, identify the step that causes the most delay to the patients, and then try to make a change to that pathway. And there are centers that have great difficulty putting patients into clinics for urgent review. Others see the patients, but they can't do urgent investigations. They have to wait 3 weeks for a CT angiogram, or the ones that do all the investigations and then they don't have enough theater lists to operate on the patient. So each center would focus on the part that will cause the most delay for them, and then try to make a service change there, and then see the results. And we're using specific performance indicators. Our primary indicator was the proportion of patients who actually managed to have revascularization within 5 days if they were inpatient, or 14 days if they were outpatient. And we plan to look at the postoperative length of stay as well, reintervention rates and readmission rates. And we offered some online resources about how to do quality improvement. So the data are collected in the National Vascular Registry, which is already set up. And initially we looked at figures from 2018 and 2019 to see where these 11 centers were. And you can see here in blue is 2018 and in orange is 2019. So you can see there is a variation. This is the proportion of patients that are revascularized within 5 days if they come in as emergencies. So there is quite a bit of variation across each center, and they're not doing equally well on open and endovascular revascularization as well. So starting from May 2020, we started doing 3-monthly data analysis and tracking this proportion of patients and giving performance reports, which we're presenting at webinars, and we were discussing what changes each center performed. We also created an additional collection of data items that each center could collect in a local database that offered more detail in the patient journey. So who referred the patient, if they were referred to a hub or a spoke, when they were first investigated, what type of imaging they had. So we have held 4 webinars so far. the last one being in May 2021. And especially in the one in October 2020, we had a session with the Leicester Vascular Institute that was open to the public and which is available on our website. And we heard from a lot of healthcare professionals in Leicester how they set up their pathway that has been proven to be excellent and reduce time to revascularization. We also put the quality improvement resources on the quality improvement webpage of the VSQ website, and we created an email for people who had queries. And really the webinars offered a platform for healthcare professionals in these 11 centers to really exchange ideas and see what worked in each center, what didn't, and perhaps find what they could do. And of course, then COVID happened. And here you can see these graphs are from the 2021 short COVID report from the National Vascular Registry. And they show the significant decrease in elective revascularization activity, both endovascular and open, that still hasn't recovered fully. On the left, you can see the non-elective activity that really had a big drop in March and April, but then soon recovered because these are urgent patients anyway. So during COVID, the units could not really engage in quality improvement because a lot of their staff were redeployed in other specialties. But a small proportion actually found that because the trusts had to do service changes anyway to accommodate COVID, they managed to put in there some extra changes for the CLTI patients and get these approved very quickly from management. So some of the centers actually made quite a bit of progress through that time. So now I'm going to present some of these changes, perhaps give a few ideas of what could be performed across the country. And I split this, and they correspond to each step of the patient pathway, from referral to admission or triage, the review by the vascular surgery team, imaging, MDT, and intervention. So for the referral process, everyone realized that we receive a lot of referrals from primary care, but we really need to identify these patients with the critical limbs that we used to say in the past, the chronic limb-threatening ischemia that are at risk of losing their limb. So a number of centers chose to do daily triage of referrals by either consultant surgeons or vascular specialist nurses and really pick out these very urgent patients and bring them into urgent hot clinics. Some of them adopted integrated online systems, such as Refer a Patient, that allowed them to track referrals a bit more easily. A center in Wolverhampton actually used the referral assessment system. This is the system used by GPs to urgently refer to the hospitals the 2-week cancer patients. So the GPs were already familiar with it, and they were happy to use it for CLTI patients. And 2 of the centers actually gave the triage of the patients to the podiatrists, because the podiatrist took referrals from all primary care sources, and they made the decision if the patient should be seen in the podiatry clinic or go straight into the vascular surgery clinic. And they put a lot of effort into tracking these patients, and even just by tracking the patients, that brought into their awareness how long the patient waits. So they were on a list, and they could see how quickly they went through with the investigations, and they had a bit of control on the waiting lists. Regarding how they achieved to actually get the patient seen by a vascular surgeon, now almost all of our centers have these urgent hot clinics with one-stop duplex. So they have sonographers into the clinic, and if the patient is seeing their concerns about the perfusion, they immediately go and have a duplex. And some centers also have same-day CT angiogram. And some centers had a very wide geographical area, and they thought it was not really fair for the patients to travel 1 hour to come to the hub and be seen at the hot clinic. So they ring-fence some dedicated slot in the existing clinics in the spoke centers, so the patient could also be urgently seen in the spoke centers and wouldn't have to travel that far. That was a center in York, a very wide catchment area. 2 of our centers use the surgical assessment unit to review the patient, because then the patient can bypass the A&E department and be seen very quickly by the vascular team there in a space that they can properly be assessed. And the team in New York actually came up with a virtual ward, which is a dashboard where the patient actually wait at home, but they're being reviewed daily by the on-call team, and they have their investigations planned as inpatients. As I'm sure you'll know, getting an inpatient investigation is much, much faster than outpatient. So in this way, they actually managed to get the patient CT angiograms within a couple of days, even though the patients wait at home with less risk of catching COVID in the hospital. 2 units, Leicester and Hull, they also do daily morning mini MDTs between the vascular surgeons and the IR department, when they can quickly go through the imaging of these urgent patients and come up with a plan to treat them either by endovascular or open or a hybrid approach. And because most units have the MDT once or twice a week. So if you wait that long, you're most likely to lose the 5-day target anyway. And the team in Birmingham actually managed to get the vascular anaesthetists that are allocated to vascular lists on a specific day to actually go and see the urgent inpatients that were identified as needing urgent surgery that week, and optimize the patients, request more investigations if they had to. So that was very beneficial, so that we sometimes have patients getting cancelled on the day of surgery because they're not well optimized, so that avoids these issues. And most of them try to gain more access to theatres, which is a major issue, and to IR sessions. And some of them managed to do that by clearly separating elective and non-elective lists. And the non-elective lists were only for carotids, urgent AAAs, and the CLTI patients. So that automatically generated more space for the CLTI patients. And finally, one team in Birmingham actually introduced the complex lower limb endovascular team, where there was a dedicated team with a vascular surgeon, interventional radiologist, and a specific theatre team that did all the complex lower limb work. So these are some of the things that have been implemented in the units. Going forward, we are planning to continue monitoring the progress. We have already seen some very good results. Some units have gone from 60% to 80% of the patients vascularized within 5 days. But we want to gather a bit more data and look at reintervention and perhaps amputation rates as well, and then share this message really with the rest of the country. So I would like to thank the teams at the Royal College of Surgeons and my supervisor, and also, most importantly, the 13 early adopter centres. We can leave them here for a minute so you can see if your centre is included in those or not. So they are the pioneers, they're doing great work. Thank you very much.